The basics of ultrasound guided injections are knowing your anatomy, okay? Any type of injection you do, whether it's a shoulder, a hip, a knee, whatever it may be, if you don't know the anatomy, you probably shouldn't be injecting it, okay? And that's why we don't do spine injections, okay? We know the anatomy, but we don't do the anatomy, okay? So spine injections are done by pain management and spine experts. Even though we've all done spine surgery, we don't feel like we're good enough to do that. So if you don't do this on a somewhat regular basis, you might not feel comfortable doing a lot of these. So practice, you gotta get on it, know your anatomy. First, become familiar with using an ultrasound before you try to do an ultrasound and a needle. Okay, please do that. It'll save you the pain and agony, it'll save your patient pain and agony, and a lot of sweat and tears, okay? Because if you start out day one with a probe and a needle, bad things are gonna happen, okay? Use the ultrasound a lot, get comfortable with that, then talk about using an injection, okay? Have an assistant available, okay? I don't do this, I don't have an assistant available in my room because I'm moving and I have all my stuff kind of planned out. But the worst thing in the world is to have your probe on a patient, the needle in the patient, and realize you forgot something, okay? Because then you're stuck. You're gonna take out the needle and come back and poke them again. I mean, it can become very problematic. So have assistant available. Make sure your patient is comfortable. They need to be seated on the edge of the bed, whatever it is. Support whatever's hurting them, cover whatever they're modest about, make them comfortable and relaxed. Exude confidence, okay? If you walk in, you're like, I've never done this, I don't know. What is it, the Geico commercials or something where the guy walks in, he's like, yeah, we'll wing it, you know? So make sure the patient is comfortable, but make sure you're comfortable too, okay? I don't ever do shots unless they're in the position that I want them to be in. Like if you can't get up on the bed, I'm liable to say, sorry, I can't give you a shot. You know, I mean, it's one of those things where this is what I'm good at, and I'm good at it in this environment. So like when I go to the hospital and I try to do a shot, it's like a 2-second process in my office. When I go to the hospital and the patient's all in a weird position in a bed, it makes my really easy job really hard. So make it the same for you every time. Make yourself comfortable. If the patient's way across the bed, have them come closer to you. Don't reach and get your hands all extended. Make sure your needle is long enough. When you're doing ultrasound guided injections, you need to have a longer needle because you need to have a path that's parallel to your ultrasound waves. The more short your needle is, the more acute angle you have to take to get where you're going, and then you lose the ability to see the needle because it becomes more angled away from your probe, right? The more parallel it is to your probe, the more echogenicity you're gonna have. So when you're back there injecting into the phantoms, we have little phantoms for you to inject to, see what it looks like when you put your needle down at an angle, and then see what it looks as you drop your angle and bring it more parallel to your probe. You'll get a lot more feedback from that. So because of that, 2 inches minimum for me. Basics on this. So in plane is longitudinal. Okay, so if you're parallel to your probe, you're in plane. If you're perpendicular to your probe, you're out of plane, you're on axis, okay? You always want to do things in the longitudinal injection, always in the plane of the ultrasound, because then you get this nice idea of the length of your needle and where the end of it is, okay? If you do out of plane where you're doing perpendicular to your probe, it's going to be a dot. Is it this dot? Is it that dot? Is it this dot? And then where's the end of your dot? Okay, so you don't know the depth of your penetration. The only time I recommend you do out of plane injection is the AC joint. It's almost impossible to get enough of an angle to be in plane and be in the AC joint. The good news though is when you inject your material, you'll see the AC joint fill up, and you can actually see the Kenalog, which is what I use. You'll see that material floating around the knee. It's almost like a little, or in the shoulder, it's almost like a little dust storm. You'll see the material. It's actually echogenic. So everything you can do longitudinal so you'll get a whole length of the needle. Depending on the pathology that you're treating, that is going to depend on patient positioning. So I would like to say that every time it's at the end of the bed, but it depends on what I'm treating. So what is their pathology? Is it the biceps? Is it the cuff? Is it the joint? Is it a knee? Whatever part of the body it is. What is the patient's anatomy like? Are they going to be able to sit in the position I need? Am I going to be able to get to the position I need? It's amazing the variability of the human species. I'll see a patient that weighs 80 pounds, and the very next patient will weigh 400 pounds. Very different way you need to treat those two patients, okay? Make sure that patient can cooperate with your exam. If they're super dramatic and tearful and real jumpy, might not be the best patient to do this on, okay? And that's for any type of injection. If I have somebody that I can't calm down and is grabbing my hand and stuff like that, not doing an injection, done. That's it for me. Make sure you know your anatomy again. You have to know your anatomy on exam, you have to know your anatomy on your ultrasound, and you have to know your anatomy of where your needle is going. And I think that's pretty much it. These are my tools. Everyone always asks me, what do you use when you inject? There's no right way. This is Dr. Baker's way. I use betadine. I like this little ampule because it's in this little pouch. I squeeze the vial. It goes down to the cotton. I can rub it on the patient. I don't have to open that little zip pouch and have all these probes on the end that get my hands all dirty. This is self-contained. I put it right back in there. I'll then use one alcohol swab and I'll dab the area after I've prepped it. I'll use ethyl chloride to numb the skin just to remove that kind of initial anxiety of that pinprick. I used to not do this when I got into private practice. I did because people want to not have any pain with it. I use a single 4x4 here. I'm very adamant about this because I'll have my girls give me like a stack of them. It'll be like 50 4x4s, and I just need one. I'm just going to put pressure on after I inject them. One Band-Aid. 21 gauge needle, okay? You wanna make sure if you're gonna use a safety needle that it has enough length to it. I don't think we should be using safety needles. I personally think it makes them more unsafe because now you're capping these things. So I use a 2-inch unsafety needle. Everybody uses gets a 5 cc syringe. I think it's really important that you use the same needle and the same syringe for almost all injections. And the reason is that part of my injection, my injection is the feedback that my thumb feels. If I'm pushing and I feel a lot of resistance, I'm in the wrong spot, okay? Whereas if I go to a smaller needle and a larger syringe, you'll have to push hard to get that large volume through that small needle anyway. So whatever your combo is that you like, make sure it's the same every time so you get an idea of what that feels like. The ones that makes it hard is the visco. So when you do visco supplementation, you go from a nice liquid material to a very thick viscous material, and now it feels different as you're injecting it, so it gets a little bit tougher to know. I use 2 cc's of 1% lidocaine, 2 cc's of 1/4% marcaine, and then 40 milligrams of Kenalog. And depending on your mix, that may be a half of a cc or a full cc. Now, Dr. Yee has a different mix. Dr. Gasser has a different mix probably. This is what I think is the most effective in my hands. When I did the research on this, Kenalog was very gentle on the soft tissues, seemed to be less toxic. When you start to mix more things together, lidocaines, marcaines, Kenalogs, everything you add to that, it becomes more toxic to your cartilage and your soft tissues or whatever it may be. There's no 100% safe material to inject. It's all the lesser of evils, right? So if you're trying to inject the tendonitis, it's probably a pretty safe thing to do. You're not trying to inject the tendon. You know, we're not trying to inject the tendon itself. Ultrasound guided injections, again, you need all of your pieces in a row. If you don't have a mobile unit to set up, then you're not gonna be comfortable where you're at because it's gonna be on a chair, or it's gonna be on a desk or something. It's not gonna be at a height that you're used to and accustomed to. So I really recommend using the stand for that. Patient positioning, all right, so we'll start with the biceps tendon. So biceps tendon injection, I like to do mine with the patient supine, okay? The reason for this, the patient is number one, comfortable. The patient is number two, controlled. What I do is I find their tendon on the short axis first. I'll then look at the biceps tendon on the long axis, and I'll center it wherever it is, where it's centered, so my hand is just straight up and down. Now that may mean that that patient's arm is against their own belly. It may mean that their arm is externally rotated and resting against my belly here, but I know where it's gonna be based on where I did when I examined initially. So I'll put my probe on, I'll rotate their arm till it's straight up and down where I want my biceps to be. That way I know where I want their arm to be, okay? The elbow is bent at 90 degrees to control that rotation, okay? So I don't want it at their side because patients invariably move. I want it here so I can control that rotation. I'll then put the transducer in the opposite hand because I want to inject from the bottom up. You could do it from the top down, but going across the acromion and stuff like that and the anterior subscapularis can be a little bit tough. I find it a lot easier to come from the bottom up, so it's always being injected by the ipsilateral hand on the biceps tendon. So this is a little video, hopefully it'll work. Uh-oh. Oh, it says it's paused. There we go. So I'll just narrate. So this patient has had shoulder pain. It's directed anterior to the aspect of her shoulder. I'm identifying the bicipital groove there, and I just make a little imprint with my fingernail. I never like the idea of marking the skin because when I prep it, that mark is always still there. So how would I clean it if it's still there? I've never understood that. So I always mark with an imprint of my finger. I'll then put my betadine blot there. I'll put a Band-Aid where I can reach it easily. My 4x4 is either on the patient or on the bed behind them. I then blot it with the alcohol swab. I'll then use the ethyl chloride, and then I'll get my probe and put it into position. And this is where it's handy to have an assistant. I'm going to go until I find my groove. There's greater tuberosity. I went past lesser. This is the top of the bicipital groove. Her biceps tendon is very degenerative, so it's kind of the length of it is kind of bad. You can see the bicep or the needle coming in. As you go through this, when there is bicipital tendonitis, the tendon itself is really thick and boggy, so you're not going to get a perfect, like, nice line right away. But as I do that, you actually start to see the biceps tendon. I'm basically outlining it, and I'm going a little bit into the subacromial space, and then a little bit into the bicipital groove, and then back and forth. I don't want to inject it directly into her tendon, so I'm going back and forth slightly so that I can fill that fluid up around the tendon sheath. And you can see the patient's not moving around or writhing in pain. This is a relatively easy injection to do. If you're going to do them, I think from a hand skill, I think it's probably the easiest injection to do to get started with, next to the AC joint, but you don't get a lot out of doing the AC joint other than just kind of figuring out your hands. So I think biceps tendon injections are a pretty straight way of doing that. Does that make sense? Any questions on that before I move on to the next one? All right, subacromial injections. Now this you can really kind of do whatever you want. There's 3 or 4 different ways to do this. You can do it from the back, you can do it from the front. I prefer to generally do it from the side. In this case, I do like to stand behind the patient. Believe it or not, I think they like to watch it a little bit, so this is one where they can see. I'll then put the probe over the lateral aspect of the tuberosity. If you want to have them come out this way, you can. I prefer not to do that because it tightens the tissue over the supraspinatus, so I like the arm to be relaxed with their hand at their side or in their lap. I'll do the longitudinal view of the supraspinatus. I'll then introduce that needle and watch it go into the subacromial space. What's interesting on this one, this guy actually was a little bit difficult. Let me see if I just hit click. No. This guy was a little bit difficult to get into his space. I actually thought about redoing one, but we'll show you what it's like sometimes, even for me. All right, so first thing we're going to do is identify the supraspinatus. So we have greater tuberosity, we have deltoid tuberosity, we have supraspinatus is in here. You're going to see this patient actually has significant bursitis, so this little black stripe between the supraspinatus, there it is. So this is the bicipital tendon, or excuse me, supraspinatus tendonitis here. Supraspinatus is here, deltoid fascia is here, and that black stripe is actually bursitis. Okay, that's a lot of bursitis, and you'll see this if you do enough. You'll see lots of rip-roaring bursitis, but this is a great view here. Greater tuberosity, humeral head, supraspinatus tendon, and then tendonitis. This one, just because of the positioning, because I had 2 of our girls recording this, I went ahead and did it standing from the front. It doesn't really matter. Whatever you're comfortable with, you can do. So again, I find my spot. I mark it with my fingernail. I'll then prep it with betadine and alcohol, and then I'll give the ethyl chloride. I'm going to try to parallel the probe, and you see how flat my hand is. The flatter I am, the better I'm going to be able to see that needle. Okay, this is all like unedited. I haven't edited anything. When you're in this and you have this bursa, I don't want to inject his tendon. So that's the really good thing about doing these under ultrasound guidance, is if you're injecting cortisone into the tendon, you're going to cause a rupture at some point. I mean, it is definitely a degradative enzyme, or excuse me, steroid. So I'm kind of going back and forth trying to find my way. He's thin, so it actually makes it a little bit harder, a little bit softer, more soft tissue makes it a little bit easier. So I want to make it perfect because I'm recording it for you guys, so I took my time and probably made it worse. But again, you can see the length of the needle. I can see where I'm injecting the material, and you'll see at some point I finally get my position where I really want to be, and then I'll really fill up that area. You can actually see here I'm actually filling up the bursa itself before I was above the bursa. And now you can see I'm really filling that thing up nicely. And that's only 5 cc's. I have partners that do 10 cc's. This is why I don't do 10 cc's. Clearly that's a lot of volume in there. I just don't think it's necessary. You're just trying to depolarize the nerves with the lidocaine, and then the Kenalog, generally 40 milligrams is enough. So that's a subacromial injection. Any questions on that at all? All right, intra-articular injections are probably where we should be doing them more. I actually don't do them very much here because I think I'm good at blind injections. Intra-articular injections can again be done in many ways, from the front, from the back. Again, what's comfortable for you, what's comfortable for your patient, that's really how you have to guide this. So the way I like to do it is from the back. I think going through from the front hurts. Any of you guys that have ever had an MRI arthrogram, every patient that I ever get that gets one of those done says it hurts and it's really a terrible experience. So because of that, I've always gone from the back, and I'll show you kind of what we do. So we're finding that posterior point 12 like we looked at earlier. Second time. So we're going to find the humeral head, and that's here. The infraspinatus is here. As soon as I get my hand right, we'll show you the glenoid. So this is the glenoid down here. I keep moving. And then the labrum is that triangle there. So that's what I'm talking about there. So labrum, glenoid, humeral head, infraspinatus, and I'm just showing the angle that I want this needle to go in. If you try to go in from this direction, which technically you could, you can see you're gonna have to traverse that tendon, and it's very tough to hit that angle. So it's better to go from medial to lateral so you can kind of dead end right at that infraspinatus. So again, I'm marking with my fingernail. I'm then gonna put the probe down, and I'm gonna prep. Put the betadine on first. I'm just squeezing the capsule. Prep it. I'll put my Band-Aid on. And this is just my routine. You never forget anything if you do your routine. People are always like, don't forget the Freezy spray. And I don't, because it's my routine. So then alcohol. Then I'm gonna get my probe back into position. You know, technically you could go and put, you know, the sterile lube, and you could use the cover that goes over the end of the probe, and sterile gloves and all that stuff. Or you could just be sterile, you know, practice sterile technique and not touch the area you're trying to inject. And that's the way I go with this. So again, I'm finding my position first. Then I'm gonna make a little poke in the skin. And then you can see I'm just slightly out of plane. I move those tissues, so I'm gonna use my probe to find my position. There's my needle coming in. And this one, you really have to make sure that you get a long needle, because you could be out, but I'm going right to the joint surface. There's nowhere that I could be but in the joint when I get there. So as I inject that, you can see it filling that up. You need to make sure that you're deep enough that you're not just filling up your infraspinatus. And then as we keep going here, we'll basically see a nice stripe going around the whole humeral head. And again, it's only 5 cc's in the whole humerus, so you're not gonna see a huge balloon distension, but you could do more if you wanted to. And that's how I do my intra-articular injections. Oh wait, I don't need to go for this. All right, AC joint, this is the one that I said you can do out of plane. You would basically view it from the superior position. You would basically palpate where that divot is between the AC joint, and then go from front to back and inject the material. Now, blind injections are the majority of what I do, okay? So again, in order to do blind injections, you gotta know your anatomy. The patient has to be comfortable. You have to be comfortable. Move quickly and accurately, but don't stab or swipe. The problem that I feel, or that I see people make mistakes on, is they'll put the needle in and then they'll move. Well, that needle is stuck in the tissue. So as you move, you're just bending that needle in their tissues. So if you need to move the needle, you need to move your hand all the way out and then go back in whatever direction you want. So it should be all linear movements, okay? Patients come to me all the time. They're like, oh God, I've had a knee injection. It was terrible. I'm never doing it again. I'm like, they didn't do it right. I mean, if you do it correctly and you move swiftly and you're not moving your needle around, or you're not injecting a tissue that doesn't have a space, then it shouldn't really hurt. If you're injecting a knee space or a subacromial space or an intra-articular space, you're filling up a void, so it shouldn't hurt to inject that. Now, frozen shoulders sometimes will be a little uncomfortable because they're very stiff, and as you expand that tissue, that can hurt a little bit, but for the most part, these things really shouldn't hurt. Again, apply steady pressure to your plunger. You're gonna know what that feels like when you do your injection, and if you're getting resistance, don't push harder, change your hand. So you'll see every injection that I do, I'm moving my hand back and forth slightly to make sure I'm getting that smooth, steady flow as I'm injecting the material. So it's not a mistake that I'm moving my hand, that's on purpose. Subacromial injection is another thing that I find people do wrong on a regular basis. If you look at the scapular Y view of the shoulder, basically if we take this bone and turn it 90 degrees, so we're looking into the glenoid, this is the acromion with the subacromial like type B or C spur. This is your coracoid, and then this is the scapular body. This is where we're trying to inject that material. Almost everyone has an upward slope from the back of the acromion to the front of the acromion. Now, every once in a while, you'll have somebody that has really bad posture or bad kyphosis and their shoulders are sloped down. So that is the one time where this changes. But the key is to put your hands on the patient, feel the back of the acromion, and feel the front of the acromion to know what their slope is. So if you're injecting this patient, that angle is all wrong. You're just putting it right into the back of their shoulder. Okay, so you're basically injecting that into their infraspinatus, all right? That's gonna hurt them, it's not gonna do what you want, and it may cause a rupture. If we're trying to get into the space just underneath that acromion. So if you're going at that angle, you're not gonna make that patient better most likely. Drop your hand and inject from the bottom up, and that's where you're gonna wanna go. So you'll see on all of my patients, I always impress, hold the acromion, and then parallel my fingers. So don't do it that way. So this is an injection of the acromion. You can see the lateral acromion, posterior acromion. Got my Band-Aid in position. I've just outlined it for everyone to see here. We'll prep it with the alcohol. And again, you can see my little thumbnail print there. Give the Freezy spray. Then I'm going to grab the arm. I can feel my front of my acromion and my back. I'm dropping my hand and I'm paralleling that position. I'm going in and out because it's a thick bursa. I want to spread that tissue, and she has no pain. She's doing totally fine with this. She was scared to have it done, but she volunteered to do it for a video, and she still didn't have any jumping or craziness. Intra-articular injections, you can go from 3 different spots generally. You can go from the front, the back, or from the top. I was trained to go from the top. We did some studies of CT guided, fluoroscopic and guided injections, and we seem to be more accurate going from the visor's portal. This might be a little advanced, but it's a good way of kind of getting an idea of where anatomy is. Our goal is to go behind the AC joint and into the joint itself. So looking at your pre-op or your pre-injection x-ray to have an idea of what those anatomical land points are is helpful. So as we look at this guy's shoulder, we have the acromion here, we have the posterior spine, AC joint. The humeral head is always slightly anterior unless they have bad posterior arthritis. The head's actually anterior, which I think is commonly misunderstood. The coracoid process you can see here. And I'm gonna go just behind the AC joint, and I'm gonna prep that area. I'm gonna go right down, usually angling about maybe 20 or 30 degrees anterior, and then lateral from that position. As I put my injection in, I'm feeling the joint line with my index finger and my thumb, so I'm feeling the rounded part of the humeral head, and it can actually shift it kind of back and forth to feel where that joint is. And then all I'm doing is aiming between my fingers until I hit the head, and basically just going straight through the soft tissues until you hit the head. We'll then inject it. You can see I can remove my hand. It doesn't bother him at all. It's totally supported by his shoulder. That injection is just sitting there. He has no pain whatsoever from this. We're going to inject the material, hold pressure on the injection site, and then put our Band-Aid on. And just to show that this is, again, something that you can do quickly and comfortably. And I'm going slow on these videos because I'm talking, I'm trying to narrate them. But this is kind of 2 views to give you an idea. We have the clavicle, lateral acromion, then the posterior spine. I'm feeling that AC joint. Just behind the AC joint, there's a soft spot. I'm going to feel the joint line. I'm going to move her arm just a little bit. I'm going to feel where the humeral head is moving, and where that moving stops becomes the glenoid. And I'm going to feel that through the entirety of the injection with my right hand, and I'm going to be aiming between my 2 fingers. It seems difficult, but it's actually very easily tolerated and pretty quickly done. Prep it with my betadine. Get my Band-Aid ready. You only forget those things one time, and then you never forget them again because you got a needle in the patient or they're bleeding. Dab it with the alcohol, give them their Freezy spray. Gonna grab that joint line again. I'm gonna place my needle into position, go until it stops, inject the fluid. I'll move in and out slightly. As long as it's going in easily, then I'll leave my hand in and inject the rest of the material. She's talking, I'm asking her, are you in any pain? She says, nope, don't really feel anything. And then we're done. 1 4x4 for a little bit of pressure there, and she manned it. Adhesive capsulitis is the most common reason we're doing those shots. AC joint can be a little bit tricky actually, and I think the patient that I show you here was actually hard to find. This patient is gonna be a lot easier to inject than this patient. Okay, look at the anatomy of the AC joint. Sometimes they're very sloped this direction. Sometimes they're sloped this direction. Sometimes they're almost fused. So I prepare the patient to know that they're gonna feel me moving. I'll push down until I hit bone. I'll come up, I'll change my angle a little bit, and you'll see me do this in the video. They don't hurt, it's okay for them. Prep them that you know what you're doing and you're not doing it on accident. That is just trying to find the spot. The position of where to put it is usually pretty straightforward between the anterior middle heads of the deltoid, usually at the end of the trapezius. You can see it very easily on her, maybe a little tougher on him, but you can almost always palpate it. So this guy, again, volunteered for an injection for us, and I've already prepped and put my thumbprint where I think that joint is. So I feel the anterior AC joint, lateral, posterior, just so I know where I'm at. I'm feeling the posterior soft spot on the visor's portal there. I've already prepped it with my betadine. Band-Aid's in place. I'm gonna dab it with our alcohol, freezy spray. And again, you'll notice as I do this, hopefully I rest the ulnar aspect of my hand. See how my hand is stabilized? I'll then get it there, I'll give a little bit, I'll move, give a little bit, move, and then I'm gonna realize that I've gone too far. Now I'm gonna come back the other direction because I'm not finding his space. There's a reason he has pain, because he has a very narrow space here, and then I'm gonna fall into that space. So you can see there I'm going up and down. I'm actually going a little bit through the AC joint there. There you go. See, I went all the way through the joint, and I'm putting a little bit in the subacromial space. These can hurt a little bit. I mean, this is the only one I do less fluid. I do 3 cc's in this, which is probably still way too much. So I do a little bit underneath the joint and a little bit above the joint for my AC joint injections. Questions on shots? I'm done talking. I know it's been a long time you've been sitting down. All right, so let's go to the back. If you have a tank top or something like that and you're not too shy to take off your shirt, that would be helpful. And we'll start examining some shoulders. We'll all be around to help out, and you can ask any types of questions on any of this material that you want. Thanks, guys.